Welcome and thank you for being here on this lovely spring evening with us for our VCSQI quarterly meeting. Tonight we have a pretty action-packed agenda. We're going to continue our collaborative discussions on the cardiology, cardiac surgery, heart team approach to our regional operations. We have some strategic planning updates and a really exciting panel discussion on enhanced recovery, not just in cardiac surgery, but also for cardiology patients with a unique angle. We'll hear from our team in Winchester. And last but not least, Gyula from ARMIS will provide us with an update on CV service line financial reporting using our blended clinical financial database. But first up, we have Sherri White, who is our VCSQI Quality Improvement Advisor, and Dr. Robert Shor, who is the VCSQI Vice Chair. Sherri and Dr. Shor will provide an overview and an update from our strategic planning exercise that we performed last March, a few months ago, followed up via survey and speaking with a number of you individually to try and really hone in on the VCSQI mission, vision, and core values. So Sherri and Dr. Shor, I will pass the mics over to you.
So first of all, thank you very much, and thanks for all the feedback and the response to surveys and everything so far, the work that's done. This is an iterative process. We are not done. This is just part way, but we did want to share with you where we are so far with the mission, the vision with a suggested upgrade, and then look at some of the items that we talked about for core values. These are, for the future, guideposts for us as we move forward in the organization. So the mission is always our highest target. The vision is our aspirational goal, and the core values are the things that we live by day by day. So with that, I will pass it on to Sherri.
Thank you very much. All right, so welcome everyone. I still have a few of you to meet. I'm honored to be here, and I'm honored to be a part of this process as you're working to enhance the mission, vision, and values of VCSQI. It's very refreshing to see how the culture kind of aligns with the values, so I can see some organic growth. So I just wanted to share with you what we all created together. Well, before I dive in, CME is offered here. These are instructions on how you obtain those credits. If you run into any issues with those credits, please feel free to reach out to Eddie or myself and we'll help you. Okay, so at the last meeting, we asked you how could we enhance our vision, our mission. So our current mission is to continuously improve cardiovascular care, patient experience, and values. So through the exercises we've done here in a group or the feedback we receive online, these are a few suggested upgrades, along with a few recurring things that we just wanted to note and share with you. I won't go through them all. I'll be sure to share this information with you, but I just wanted to give you an overview of where we are now. So with this said, I would like to introduce you to the new proposed mission, which is transform cardiovascular care to improve patient experience and value. So just wanted to get a feel. How do you feel about this? Do you feel this hones in with what you feel as the core value or mission for VCSQI? Shake of heads. That's always positive. Excellent. A lot of shaking heads. Excellent. All right. So the vision, we did the same thing. Our current vision is to optimize heart care outcomes through regional collaboration and innovation. Again, I just extracted a few recurring themes and keywords that were just constantly reoccurring. So with this said, let me introduce you to our new vision, proposed vision rather. To optimize heart care outcomes through national collaboration, innovation, and research. Research is one of the words that we constantly hone in on. And Dr. Shor?
Yeah, so the one thing that obvious changes in addition to research was regional to national, and that came up in subsequent discussions. Is regional too restrictive? And again, if this vision is supposed to be an aspirational goal, we want it to be aspirational, and so we thought national was more reflective of that vision. We've had conversations, or some of us have had conversations with people in Michigan, in North Carolina, in Seattle, and other places, and so if in our big vision, whether it's achievable or not, it's aspirational. That was one of the changes that we made to it, in addition to the comments made about research.
Excellent. So just get your feelings on this. How does this feel? How does this hone in or sing to your heart as it relates to the vision of VCSQI? Does this align with what you're thinking? Okay, pretty good.
The one thing I would also say is this is an iterative process. We're not done with this. So you will see these slides. We want you to think about it, and we want to get the feedback to make sure that we get it right, because in the years coming, this is what's going to be guiding us. So we'll think about it. The next thing we talk about is core values. In any organization, what are those things that drive us, or essential ingredients?
And so, well, the current core values are passion, innovation, and collaboration. So the proposed core values that we have now, and please note the acronym VCSQI. The V stands for value-based best practices. C stands for collaboration and transparency. S is stewardship of healthcare and cost. Q is quality and patient-centered. And the I is innovation, data, and analytic-driven. Again, we're going to continue to work on this, but I do like the VCSQI, and it embodies it all. And the values, to me, coming in new to this foundation or this area, it came to surface organically. So this is something that is true here.
My additional comment would be is that we had a somewhat different list, the same basic values, but organized a little bit differently. And one of the things you want with any of this, the mission, the vision, and the core values, is that they be memorable and to the point. And so Dr. Sain said, well, why don't we do the core values as VCSQI and just transform those to VCSQI, and that's what we did here. Again, this is an iterative process, and so think about it. If you have upgrades to these proposed core values, let us know.
Excellent. Yeah, this is beautiful. Okay, so what's next? We have a proposed mission, vision, and our core values. So how does this align with what we're going to do in the years to come? So the first step is, my role is the Quality Improvement Advisor. We changed the name of the program that I'm helping to lead from Quality Improvement Initiative to the Quality Alignment Initiative. We don't want you to feel like we're putting more work on you, but we want to be with you in parallel and sync to help you improve the level of care that you provide to your patients. So that's the name change. Also, based off the input that you provided us, you helped us to determine our strategic focus in the years to come. We want to make a larger footprint across the state and the nation. It won't take tomorrow, it won't take a year. It'll take some time, but collectively we will get there. The way that we're going to get there is by strengthening our marketing and collaborative strategies. We want to increase our collaboration efforts internally and externally. While doing so, we want to reduce the burnout of our physicians, our data managers, nurse practitioners, engage our patients, and also share resources, which is the foundation of VCSQI. We also want to harmonize cardiology and surgery. So ways that we think we can do that is integrating the data models and standard of care, and identify crossover and develop standards of care together. We want to continue to educate. Many of you had mentioned a mentorship and a shadowing program, so let's build that together and see what we come up with. Okay, so how are we going to do this? This is a high-level action plan. So we want to enhance our membership, and the way we're going to do this is by developing strategies and just do a lot of outreach to the hospitals that we have not yet obtained memberships through, cardiology and cardiovascular surgery. We want to grow our membership, obtain the buy-in of more administrators, more clinicians. We want to seek continue to seek membership for the remaining health systems within Virginia through outreach and establishing core contacts. We also want to enhance our communication strategies. So during our quality meeting, we spoke about our enhanced website, which will be more uniform to allow us to collaborate better by way of providing you with contact information for one another or sharing your resources online as it relates to standards that you're using currently. Again, we want to share best practices and standardized protocols. So as we work together and learn what each facility is doing, let's build something phenomenal together and standardize that protocol through the VCSQI membership. And again, continue to educate. Provide a forum to enhance further development and knowledge. Again, that's through the mentorship program and targeted task force. All right, and overall, quality improvement will reduce costs, and all that together enhances value. So now we are at enhanced collaboration resources. This is kind of repetitive for our quality committee. So on Monday, I'm going to send out a mass email just to let you know how to subscribe to our mailing list. We're now using MailChimp so we can automate our directory, if you will, so that poor Eddie, is no longer updating the 300-page document of contacts. So we're going to use SurveyMonkey to help us do this on an automated basis. You're going to be able to self-subscribe, self-unsubscribe to the mailing list. It's going to also populate or generate newsletters for us. You communicated to us how often you wanted to receive communication from us. Currently, the communication standards that we have now is perfect. We communicate things when it's important to you, you like that, but pretty much you want to receive it on a monthly basis, which is where the newsletter comes in. Through the subscription, we're going to generate an online directory, and this will allow you resources to go online to find out who is a counterpart you can reach out to answer the questions that you may have. We're going to continue to do the committee communications, and then through this website, you're going to be able to update your preferences. So this is just a snapshot of the new website the new section of the website that will be active Monday. This is how you get to it in the member section. The password will be Richmond 2019, and I'll be sure to include this as well. But this is just a snapshot of what is to come. And if you can think of any other mechanisms that will help you to be more collaborative amongst each other, let us know and we'll figure out how to integrate this in the system. All right, so this concludes the strategic planning session. Do you have any questions? What are you thinking? What are you feeling right now? I'm learning from this group that no response is a good response.
Have we put people to sleep or?
I think it's a refreshing, innovative idea. I think it's needed.
Yes.
How many facilities right now, how far off are you from having both the ACC and STS, like getting the cardiology engagement? How many facilities are actually?
So I think we have around roughly 20 of the cardiology. The two major systems that we don't have are HCA and Bon Secours. And so we're working on those. And I, from the HCA standpoint, had talked to and presented to the regional medical director, and I've talked to some of the CEOs, and I went locally. There was interest locally, but there was not interest in the big system. So from a strategic standpoint, if you have a better way of approaching it, create a groundswell of interest, we would love to see that. The second is, as our cardiology piece matures, the way the surgical piece has, where we can show a quality and cost improvement, my thought was then to come back, at least at that point, where we have more data rather than a vision, to be able to share and see if we can bring them into the fold.
I appreciate that thoughtfulness, but I understand that it's going to take some grassroots too. So.
Right, and I can tell you in my local HCA facility, There was a great deal of interest in participation, and it was discussed at the cardiovascular service line meeting, and it was requested to go up the chain of command, and you can imagine what the response was. So I tried both from the top regionally and from the bottom up, and we've got a little bit of work to do, but I'm a half-full kind of person and optimistic in the long run.
Any other comments, feedback, suggestions?
So from the strategic plan piece of this, you will get the work that's been done so far, and I would personally, and we all would, appreciate your time to take a look at it and give us your thoughts and upgrades that you have for this. I think also what we'll probably do until we've finally got a final product is spend a little bit of time at each meeting, if you're okay with that, Alan, just to kind of keep the momentum going with this.
Did you want to go over the
Oh, sure.
reports as well?
So we have just a few slides, some of the preliminary stuff, and I will say that we have a chapter exchange program. The Virginia chapter of the ACC has a chapter exchange program with the British Cardiovascular Society. So last week I was in England, and I had the pleasure of presenting a little bit of what we've done here because it's unique, and to share some of the cardiology data. So this is just an interesting slide. You talk about improving quality, and part of the way you do that is by reducing the variability of care. And this is an interesting slide looking at the percentage of femoral versus radial access. And what you've got is low, medium, and high volume facilities. And so what I find fascinating is that a couple hospitals in the medium and high volume, you have a very high percentage that remains femoral, and yet we know that statistically there are fewer vascular complications by doing it radially. So what this slide points out to me is that we have considerable variability of care, and we have an opportunity to hopefully positively impact complications and quality and cost. Next slide, please. This is a vascular access site versus post-procedural length of stay. And I think, again, you can look at radial versus femoral. And also what we've listed is VCSQI and NCDR data. So one of the beauties of when I was showing slides with regard to the surgical data is that the surgical data, the STS versus STS, was always better than the STS, that is the VCSQI data was always better than the surgical STS data. And what this to me shows when we look at post-procedural length of stay and some of the other things, we've got some opportunities from the cardiology side. It points out a variety or variability in length of stay and in access issues. Next one, please. This is the composite death emergency CABG stroke RTVR in all cases for 2018. Again, low, medium, and high volume. And again, showing the VCSQI average and the variability in care. And interestingly, it may be in part an issue of patient selection, but some of the lower volume institutions have very good outcomes. And conversely, those sicker patients may end up getting transferred to the higher volume centers that do the riskier patients, but this is an opportunity to dive into that more deeply. This is not risk adjusted. We will be doing correct. Yes. We will be getting the risk adjusted data that will be able to account for some of those differences. Next. This was just a similar slide for AKI and shows that at least based on how we've measured it, we have an opportunity to improve our AKI versus NCDR at our sites. Next one. And then we had a number, we're beginning to get our data from PCI review. There's some issues that we've been wrestling with to get the reports better. But we've got preliminary data from 3 sites. The overall success rate is over 90%, but remarkably, there were a number of patients that appeared to have less than 50% stenoses intervened on, and that's going to require a greater and deeper dive for the institutions. That data, as I understand, has been given to the institutions for their review. Our purpose is to identify issues and then to refer it back to the institution for further review. We don't want our participating hospitals to wake up one morning and find their names in the front of the Washington Post. And we want to be able to deliver safe and quality care for our patients. And that's really just a very brief overview of what we have from some of the preliminary data that we'll be looking at. We have some charges data. We are creating the cost data much the way the surgical side has done, and we'll be applying that. In general, the charges for most of the complications double the charges when there is a complication versus when there is not. So in the same way with the surgical side about improving quality and cost, we have real opportunity to do the same sort of thing on the cardiology side, and we'll be pursuing that. Any questions? Yes, sir.
Was there any correlation between access and renal failure? The reason I ask is because we know there's more vascular complications that would lead to more transfusions. And secondly, I don't know what is there more or less dye given with one or the other that may affect that?
So I think from an access standpoint, I don't know that there's a huge amount of dye difference, but we can look at that. We certainly have that data from NCDR, or can get that data, and we'll look at it from our standpoint. My preliminary look was I did not see a huge difference, but that's one of those areas we have to, I would not be surprised if there is. We need to have a larger N, and then we'll look at it, and that'll be definitely something to look at. My belief is that the femoral cases are going to have more vascular issues, and that will drive the cost up, but I don't have the answer to that specific question. Yeah.
And looking at the data for the radial versus femoral, do you have a certain area where that's happening? Like, can you look at the data and say, okay, this might be happening in Central Virginia as compared to Southwest? That would be, you'd have to wonder culturally what's going on there too.
Right. So this is, from our perspective, great question, our perspective preliminary, and we need to dive a little bit deeper. And this information is being shared with the institution, so they'll probably find, why do we have so many femoral when everybody else is doing radial? Other questions? Comments? If there, also one of the things I would ask is if there are specific things that you want us to be looking at as well, we're happy to use the energy to be able to look at that aspect further. Okay, thanks.
Well, thank you, Sherri. Thank you, Dr. Shor. This is a great first step with the cardiology data, and I think more good things are to come here on this piece, and also with our strategic planning exercise. But next up, we're going to shift gears a little bit. We are going to move to a topic that we've spoken about a couple times in previous meetings, which is enhanced recovery. We have previously spoken just in the sphere of enhanced recovery after cardiac surgery, or ERACS or ERAS cardiac. We'll also get a different perspective on enhanced recovery in the cardiology space. But I'd like to introduce our panel discussion members, which will include Winchester, Mary Washington, and University of Virginia. Up first will be Kayla Roberts from Winchester, who will speak to her enhanced recovery protocol and research that she has done for the cardiology space. Kayla, I'll turn it over to you. Thank you for being here.
Good evening, everybody. So I was asked to present what we're doing as far as ERAS goes and from the cardiology perspective. So most of you may be scratching your heads as we kind of did it first in our arena. So implementation at Valley Health, so really our ERAS journey started with our surgical OR department in 2014. They formed a team that really didn't involve cardiology really till early 2018 this year. They did a lot of shadowing, programs, research, lit reviews, and then pulling together the right team members. If I recall correctly, it started first with our bariatric program and then expanded throughout the departmental OR at the facility there. So we have 6 cardiac cath labs at Winchester. 4 of them are solely dedicated to cath. We have one that floats to EP, another EP lab, and a hybrid room. So how this came to be for us and how we got on the topic of conversation throughout the organization and specifically in cardiology and cardiac surgery, we have clinical council meetings where we like to get together and intertwine our department groups because there are certainly things that we like to work team focused and patients that cross both of our arenas. Through topics and conversations and different quality initiatives coming up through the organization, we had identified listening to one of the anesthesiologists that they were starting to implement some of these ERAS protocols, and a few of us were sitting there listening to ourselves and listening to them talk and thought, well, why aren't we implementing some of that for the cath patients? And so initially we brought this back to the cardiologist and they said, well, we can implement some things for the patients getting anesthesia, but these really weren't the patients that we really wanted to focus on. So we took the basis of ERAS and what that was and started working in our own clinical council groups and just really wanted to work through what we could adopt that they're already doing in the surgical side that could cross over even into the outpatient arena. And so the main areas that came out of that were education, NPO, that was a big topic, anesthesia, which I'll get into, or even Versed and fentanyl in the lab for sedation, and then early ambulation and early feeding. So pre-op education. So most of you are all in the era where we're doing patient satisfaction, trying to boost scores, getting physician feedback, getting staff feedback. So a lot of feedback that we were getting from our patients, even though we thought we were doing a good job, is even coming in and prepping, they didn't understand what they were coming in for. There was a lot of miscommunication, a lot of misunderstanding. We would go in, we would explain. We have the same nurses, the same department that they go through, our own specific holding area department. A lot of the staff who have been there at least 7 years or more. Patients going through there still didn't understand. Then we would have a cath team going over there, speaking with them, all saying the same language. They'd go get their cath, go back to the holding area, either be admitted based on whatever they got done or discharged home that day, and they were still leaving and filling out the survey that what we were saying and what we were doing, they didn't understand. They didn't remember what we were saying, and they came in, and some unfortunately couldn't get their testing done because misunderstanding with medication and et cetera. So it became a bigger project than we had initially intended, but the first thing we decided to do was take a look at where all the information was coming from and to try to standardize it. So at our organization, there are 2 cardiology practices. One is significantly larger than the other. So the main referrals for the cath department come from those offices. However, we do have primary care physicians that feed in. So one of the biggest focuses was standardizing what everybody was saying to the patient. So we reworked our pamphlets. And we took focus on the feedback of what our patients were saying and try to explain them. We were also doing some research in the organization and reworking pamphlets to base everything and all reading on a 5th grade education level, because that was some of the research that we were getting back on how to reach patients. So we worked together as a team. This involved multiple cardiologists, multiple staff, nurses, and offices, and we redeveloped our pamphlet. And we reworked some things in it. What did they need to know in it? Is it going to hurt? What are we setting up as our experience before they come in here? What are we telling them to do before they come? Are we all agreeing? Is one physician telling them to hold a med 3 days prior, and is the other physician telling them to hold it 2? And then when they call the department and we gave them their pre-op instructions, we said something completely different. We were identifying those errors. So this ended up being, for now, our final document that we all ended up agreeing on that we were going to use. So we broke it down in days, and actually as I speak, we're actually re-amending this pamphlet based on a few things we have also identified. So even though we thought we were done, we've re-amended it 3 times. But some of the key things we did change. We were really clear, or what I think is clear. So when you tell people they're NPO, they're nothing to eat or drink by mouth, those people are coming in and not even brushing their teeth. So that was another initiative throughout the hospital. I know we all kind of chuckle, but that we were seeing oral hygiene is an issue, and it leads to other issues throughout the admission. And, when you're a high volume center and your staff's, plugging through and there's call-offs or vacations, oral hygiene gets skipped. So we thought, well, why are we giving them that instruction? It's silly, it's outdated, so we need to change it. So we made changes, agreed on meds. We changed to follow Rasp protocol in the hospital. So we are no longer making our patients, so we include the NPO, but we allow them clear carbohydrate liquid now prior to the cath 2 hours before. So in addition to allowing them, as they can be scheduled at different times, we also make this adjustment throughout the day. So all of you are familiar on the cath side, emergencies can come in at any time. So when you became the first case, now you're not going to lunch. We have our nurses be reactive and not immediately responding to those patients and taking them the clear carbohydrate liquid. That keeps the patient hydrated, it keeps them happier, in a better place, or not, and it also can help for kidney issues. So we standardized this pamphlet, handed it out to every place that could refer patients to us, and then when they are calling and we are doing pre-op appointments, this pamphlet is what we discuss with the patients. We also use same verbiage. So even when you come into our facility, we're all quoting the same times, so clear understanding, clear education. In addition to this pamphlet, which is a change that's not out, we also created a video that we linked to the internet and also gave to the offices so the patients could literally get the experience of what it was like to come into the facility, see a lab, walk through it, go on the stretcher, see different access points, what it was going to be like, if they got admitted, if they didn't, and kind of a journey through the place in 5 minutes or less to give them expectations prior to coming in. So they get pre-phone calls, and we also started discharge phone calls. So any patient discharged from our unit gets immediately discharge phone called the next day. If it is a Friday, they are followed up on a Monday, of course, with instructions asking how they're doing, how is the feedback, is there anything we can do, anything we can improve on, and what are their needs, to kind of close that loop and see if there was anything we can build off of. Interestingly enough, through this journey and what I mentioned to one of the changes on there, that was a lot of writing, but if you noticed on there, we note in the pamphlet that we're going to give you sedation. Well, that's in fact actually no longer true at our organization. We have one physician right now who is not sedating his patients at all for their cardiac catheterizations. So we are making the change to the pamphlet because we don't want to be setting that expectation. We want these patients to come in. We want them to have their conversation with their cardiologists. We want them to feel comfortable going in. We want them to agree, and we want it to go well. So that was initially a knee-jerk reaction for everybody. And our biggest fear was really the patient and their comfort level, and then it was going to hurt. So our cardiologist is very passionate about this. He ended up sending articles to the staff in Europe. Most labs are not doing that. In fact, one of these studies quoted 90% of cardiologists feel that their patients would want sedation. 60% of cardiologists in Europe think only 20% of their patients would want sedation. So we thought this was interesting. He was really passionate about it, provided some data and literature, and so we allowed him to do so. And interestingly enough, not only do every single one of his patients love him, they come out of it happy, they are not nervous. It has not impacted his patient satisfaction scores, but skyrocketed him. This is the first month that he has not been the highest in patient satisfaction, and he's not dropped his harm or mortality or anything by doing so, and these patients keep raving about him. And in addition, when you break down his scores, because you can break down the feedback, they're not leaving confused, and they understand exactly what they were told and exactly what they had done. So we're trying to slowly adopt that. It's slowly spreading, and we've been sharing those feedback from the patients and the scores throughout. And you can see, this is just a snippet up in the corner. This is compared to the average, and this is the specific physician, and you can see his scores are much higher. And he is not one of our low-end numbers. That's an N of 41. He's one of the higher ones. And that's just another article, and then that just comes back to, depending on what you're doing for the patients and use of fentanyl, there's lots of literature out of there, also delaying medication absorption in the gut. So then another thing we did for ERAS that applies to cardiology, always about early ambulation and discharge and walking, so we implemented a same-day discharge program. This again, so patients could come in, maybe sedation, maybe not, and depending on their intervention, based on our criteria here, they could go home that day. And this also helped us, and I didn't know we were going to have that slide, we are majorly using the radial artery now, which also allows our patients to ambulate early. We get them up, we walk them around. They can be comfortable. They don't immediately come out of the procedure having to lay flat on their back for 4 hours. They're immediately able to eat, get the gut moving. They're able to get carbohydrate liquids. And most of the radials can be same-day discharge home. It's less risk of complication. And it's ultimately more ease for them. They immediately get to sit up and they're happy and smiling. They can make direct eye contact with a loved one. We don't have to special angle the bed. And there's no risk of them lifting their head and popping their groin. So that's just some few things that we've adopted. It's a different perspective for cardiology versus surgical, but there are things that you can pick out from ERAS that have worked very well at our facility and I think would work well at yours. Thank you.
Actually, does anyone have any questions you want to ask before she have a seat or while she's seated?
What has been the response from that, the non-sedating interventionist? What about his colleagues? Are they more interested in that approach now?
They are more interested in that approach. So they're not all head on like he was. But slowly we've seen some of them watching him. And so the best thing for any of them that we could ever do is provide them the data. And the patient satisfaction is really what screamed louder than words for them, to show that in fact didn't decline, that this mortality is still okay, it's still good to do, and that the patients are leaving happier. And at the end, that's what we all want. So just continuing to reinforce that and show them they're all slowly adopting on.
Wonderful. Thank you, Kayla. And then I'll ask you to I'll ask all of our panelists to sit in front here once we're done with our summary slides, or whenever you're comfortable to move up there. But I especially want to recognize Kayla, who gave me a call a couple hours ago saying that she was with a couple patients and she didn't know if she could make it down. So just wanted to show our appreciation for hopefully not breaking too many laws on your way down here, but yeah, and then not stranding Chris without a ride. Indeed. So our next panelist is the Chief of Perfusion and the Program Director for Open Heart and Structural Heart at Mary Washington. Mike will speak to ERAS and how Mary Washington has implemented some different protocols across their program. And I will pass you the mic, Mike, once your slides are working here.
Sorry about the delay. So I'm from Mary Washington Hospital in Fredericksburg, Virginia. A couple years ago, we actually had an ERAS program for colorectal, and our ERAS coordinator, she was put in contact with me to help her, kind of guide her through our health system because she was new to our hospital, and just help her with kind of the workflow of some of the tasks that she was given, and how she could work with the infrastructure at our hospital and get the outcomes that she wanted. And so that went on for a couple years, and our colorectal surgeon, he actually left our facility, and our anesthesia partners, they had approached me about developing an ERAS program, and that was a number of years ago, and it really hadn't taken off in cardiac surgery. But about 2 years ago, I went back and I presented that to our anesthesia partners, and at that time we were getting ready to roll out our Epic EMR, and we really felt like with all the energy focused on that, it really wouldn't have been a good time for us to start a whole new process, especially with all the building and the rollout of the program. And so what we did over the course of the next 6 months or so is we continued to look at the literature. We reviewed what some of the programs were doing out there. And we looked very hard at the elements that were recommended in the ERAC Society consensus statement. And we really felt like we were doing about 75 to 85% of those measures. And I think for all of us who've been involved in the atrial fibrillation prophylaxis, the early extubation, the blood sugar control, the antibiotic stewardship, we're really doing a lot of ERAS really for the last 10 years or so. And so we try to look and see what aren't we doing, and we made a list of those things, and we tried to pick those things that we felt that would marry well with our program. And to be honest with you, the interesting thing about ERAS that I thought was different than what we've been doing the last 10 years, a lot of these measures that we've been trying to improve are really driven for clinical outcomes, but we really, I hate to say it, they're not really patient satisfaction focused. The things that we identified really we felt were going to help us with patient satisfaction. And the cornerstone of our program really was the pain management and the PONV. I worked as a PA on our floor for about 8 years. I round on our patients quite a bit, almost daily in our ICU and on the floor. And one of the things I notice is after patients are extubated, they're extubated in 2-3 hours. You go to the ICU, how are you feeling? Patient's holding up a basin underneath them, and I'm sorry, I'm nauseated, I'm really not feeling that great. The next day, you go to the ICU, you've done with rounds, you go in and talk to them, and they're like, I'm just not really able to hold down fluid. And then the next day, how'd you do? Are you walking? And this isn't the norm, but this is the one-off patients here and there. And I was able to walk today. I'm really hoping that I'll be able to walk 3 or 4 times tomorrow. And so we saw that patient. And then you see the 90-year-old lady, and you go in and you talk to the family, and then the adult child walks out in the hallway and says, Mom's not right. She just kind of stares off at the wall. She's not really conversing with us. She seems down. And then you talk to the 90-year-old man whose wife is, she's in the ICU, and he's like, God, I'm so scared. My wife doesn't even recognize me, and she's making statements that just don't make much sense. And I'm really nervous about taking her home and taking care of her because, to be honest with you, she takes care of me more than I take care of her. And so we realized that while there weren't a lot of those patients, there were a number of them that impact our outcomes. We only do, 300 hearts a year. Only takes a few people to make to skew your numbers in the wrong direction. And so we kind of focused our, as I mentioned, our cornerstone of our program was for pain management and to reduce PONV, to try to reduce the gastric complications, reduce the incidence of delirium. We have been working on mobility for a long time, and I know I heard this from, I believe, the lady from Henrico. Nursing shortage, change in staffing, you see mobility go like this in adoption. It's painful. But we really got good traction in the last couple years, in large part because of our work from our nurse navigator and the nurse manager on that floor. They've just been very much champions for that. But when you have patients who have, GI complications, or if they have delirium, they're not going to get up and walk when they're so confused. They got to stay in bed. And so we felt like this is really a great opportunity for us to improve patient satisfaction and kind of address some of these issues. And at the same time, like other programs, we adopted the Move in the Tube this past year. And so they all kind of work together in tandem. And so I won't lie to you. I'm not a expert in anesthesia in any way, shape, or form. But we adopted, initially we had talked very strongly, we were about 90% sure we were going to adopt a methadone methodology. And then we kind of got nervous because we started talking to other facilities, and there was some concern about patients kind of being over-sedated. And we thought, you know what, I wasn't the first to buy a beta VCR. As a matter of fact, we didn't buy a beta VCR. We waited until everybody else did and realized they weren't going to work well. But I wasn't the last one to buy a microwave, so we kind of wanted to wait to see how the methadone worked with other facilities. And we're getting to that point where we think that we're probably within the next 6 months to a year, we'll start doing methadone on select group of patients and see how that impacts it. Because we wanted to make sure that from an extubation standpoint, we didn't slide back. So we just adopted an opioid-sparing protocol, and basically using Presidex and ketamine, and then isoflurane throughout the procedure on bypass and with anesthesia. Preoperatively, we're using a PONV low-risk and high-risk protocol, very standard fare, Zofran, Decadron, and then in our high-risk patients, they're getting a scope and Phenergan. We really not use that very often, to be quite honest with you. Most of our patients, I'd say 90% of them have just been Zofran and Decadron. And then we also dovetailed that in with the nutrition component, and in large part because we saw good results with our colorectal using the nutrition part. And we reached out to our APIT representatives, and they were really great in working with our nutrition and food services and just our entire program and kind of getting us set up with the products we need. So we do 5 days prior to surgery, we do Ensure Immuno or Ensure Plus for the inpatients, Immuno for the elective patients. And then the night before, they get Ensure Pre-Surgical Clear. They take 1 bottle, and then that morning, our diabetics take a half a bottle, our non-diabetics take a full bottle. I will say, and we've been debating with our Abbott rep, who's actually sitting at our table, about the benefits of using the full bottle versus the half bottle in the diabetics. But we did see some hyperglycemia in the OR, and just because we were nervous about it, we thought we're going to pull back and take a look at it a little better. But we really like what that's providing for us. It helps with insulin resistance. It helps with GI motility. It helps with gastric emptying and the carb load. Patients aren't going to the OR in that fasted state. We have not had any issues with aspiration, some of those things that we were concerned about. They drink it within 2 hours of going back to the OR. Haven't had any issues with that. That's worked out really well. And then intra-op, as I mentioned, we use ketamine, we use Presidex. We use a little bit of fentanyl, only two of Versed the entire case. We redose with IV Tylenol. They do get Tylenol PO in same-day surgery and Neurontin, and then we redose Tylenol every 6 hours. It's rare that we redose in the OR, but we do redose with IV Tylenol. We do reverse with Shigamidex in the ICU on arrival. Have not had any issues with that. I will tell you, years ago, we were reversing patients with neostigmine and Robenal, and we had some crazy results from that. And we've had no issues with using Shigamidex. It's been wonderful. Initially, extubation-wise, the nurses were going, we really don't like this. It seems like they don't wake up well. Your extubation times must be terrible. But in all honesty, our extubation times have been shorter. I think some of it, like post-op nausea and vomiting, has been just that, that awareness. People are saying to me, patients are a little bit more nauseous since you started that. Well, you know what? We really weren't doing a great job of documenting it beforehand. So like I mentioned, we went with Epic. We built some documentation tools in Epic before we went live with ERAS. And so I think we were just a little bit more attuned to it and more attentive to it and documentation. But we've seen an improvement in that as well. I will tell you, we use Neurontin, as I mentioned. I had a herniated disc about 4 years ago. I took steroids and Neurontin. I had every side effect you could ever imagine from Neurontin. I took it one day, and I think my wife was afraid for me to come home. She actually had to come to work and drive me home. I really wasn't a fan of putting the Neurontin on this protocol, but I will say that our intensivists really believe that Neurontin has helped with pain control. I hope if I have to have surgery at Mary Washington, they withhold the Neurontin, because I'll probably be part of the delirium group. And then we also added lactulose. That was another recommendation that I believe one of our anesthesiologists got from WakeMed. And so we use that once they have their first bowel movement. We stop it. That's actually helped with GI motility. Haven't had any major issues with that either. What I will say is just our ERAS program really is just really focused, I think, on, I hate to say on one area, but everything's kind of entwined together. That whole pain management, PONV, delirium, mobility, that has all kind of come together. And our initial results, I will tell you, I don't have a ton of data. We've only been doing it for 5 months. But what I will tell you is that we've had a significant reduction in morphine equivalents. We have made some adjustments from our rehabilitation nutrition. I'm kind of off because of my talking outside my slides. I apologize. We have made some adjustments from hyperglycemia, but we've noticed our patients do love the nutrition products. We've had no complaints. When we hand patients electively, they get coupons and they get a bag that has all their products in it. So they take the Ensure Immuno beforehand, they take the Ensure Pre-Surgical Clear the night before and that morning, and then they get Juven for 14 days afterward. Juven is their wound healing product that has a lot of immune modulated HB, what is it? HMB. It's got taurine, it's got a bunch of good stuff in it. I will tell you that anecdotally, one of my close friends, she's one of our administrators, she had major surgery, and she just wasn't healing. She had 4 revisions of her hip and had a wound vac, had to go all the way down to the bone, wasn't healing for like 5-6 days. And I met with our Ensure rep, and unrelated, she gave me some Juven samples, and I actually took them in the bag and dropped them off at the lady's house and put a protein shaker cup on her porch and said, drink these twice a day. And after about 5-6 days, she said that she started to notice a much quicker granulation and less drainage, and she healed quickly. And so that was good because I needed to go to her and ask for the money. And so that worked out well. But I'm really happy about how the nutrition aspect of our program, because I don't think we were really looking at all those things very well beforehand. And I know I was talking to Linda about it. For larger programs, I think financially that's probably a huge cost, but for us it wasn't. We have an agreement with Abbott for food nutrition, and so we really get it at a reasonable price. And for what we're getting out of it, I think it's been pretty helpful. One of the things, on our conference call, April had mentioned that they're doing a lot of work with their prehabilitation. I will say that we're moving in the direction of doing more of a frailty testing. I've talked to our navigator about kind of adopting some of the TAVR processes we have for assessing patients for frailty. For instance, we had a patient who was in his late 50s recently, and we send all of our aortic stenosis patients to the valve clinic to be evaluated, regardless of whether they look like they're SAVR or TAVR. This guy looked like he was 100% SAVR. And so we brought him in, we did his frailty testing, and he had a grip strength of 5 on both sides, and that's pretty low for a guy. For a gal, it's pretty low. Really failed his CATS ADLs, and his albumin was borderline, and he ended up going to get TAVR, and believe it or not, our average length of stay was around 2 days, and he was in the hospital for 4 or 5 days. And so I think it just speaks to the need to develop this part of our program a little bit more. I don't know that we have the resources to commit a PT to be able, a physical therapist to evaluate all patients. But I think we're going to work on developing a protocol where we do that baseline frailty. We already do the walk test, but we add those other measures and then identify those patients that we think probably need to go get a PT evaluation. We do that for all of our cancer patients. Our thoracic surgeon does that. We have what's called the STAR program, where physical therapy is involved in all those patients, but we really aren't doing that in cardiac surgery, and I think that with cancer patients, it's actually paid for, whereas in cardiac surgery, it's probably not covered, and so that'll be expense for patients. So we'll make sure that we're mindful about that. The other thing that we did, which I'll be honest with you, has been probably the biggest thing that people have loved, is a sleep protocol. You have these orders that say up in bed all day, 12 hours, want you to walk 4 times a day, but in the meantime, we're going to get you up all night long, we're going to check your blood pressure, we're going to get you, we're going to draw your labs around 4 in the morning because our PAs want it at 7 when they come in. We're going to get you a chest x-ray. We're going to give you your meds around 10 o'clock, but sleep well, and tomorrow we're going to bust your ass. My son's at Fort Knox, and he's in officer school, and he said, "It's crazy, Dad." He said, we have to do watch at night, guard watch. We have to do this. We get an hour's sleep here. We get 10 minutes sleep there, and then the next day they want us to be on point. Well, we're asking our parents to do, or our patients to do the same thing. And really, to be honest with you, any of you who have kids, 20 years ago, you get up in the middle of the night, you feed them 4 times, you're changing their diapers, and then you go to work, and you're like, oh my God, how am I going to do this? But we're asking our patients to do that. We get them up all night, and I tell you, we adopted our sleep protocol, and basically what we did is we realigned our labs with radiology all of our imaging and our labs with the laboratory and radiology. We have our meds passed no later than 9:30, 10 o'clock, and no earlier than 6 o'clock in the morning. And as long as they're hemodynamically stable, we give them 7.5 hours of sleep. And right now, the patients really like it, but I think the biggest gauge for how much people appreciated it was when we introduced it. We had about 6 or 7 people on the floor, and for 1 or 2 days, they were on the old school. And then we rolled out the sleep protocol, and they were like, oh my gosh, this is amazing. They get a full night's sleep, and then they can get up, and they can sit in a chair all day, walk 4 or 5 times a day, and it really helped with our mobility. And then the next part was the delirium screening, and that's actually a big meeting tomorrow. We're getting ready to roll that out. That was a big process, just getting the appropriate documentation in Epic for us. And then working on non-medical treatment for delirium. There's a lot of material out there that talks about cognitive exercises using iPads that have games on it. We have a transition space between our ICU and our step-down unit, and it has beautiful glass walls. You can see outside. We're actually turning that into what's called, and I didn't make this name up, our ClinSpec did, but it's going to be called Stress Toolbox. And we're kind of refurbishing that space so patients can come into that space with their family members and with our nurse navigator and with their family members, and they can work on cognitive exercises, whether it's puzzles, they can draw, they can use all of our patients get an iPad. There'll be games on there, so there'll be word searches, there'll be all kinds of cool stuff on there, crossword puzzles, to kind of help them from a cognitive standpoint. It kind of sounds dorky, but to be honest with you, I think that anything we can do to get these people back to where they were baseline, I think we'll do them a good service. So those are some of the things that we're doing. I will say with the sleep protocol, as I mentioned on here, some of the things we do, night shift, you'd like it to be quiet, but sometimes it's not. but we're really trying to create that environment, dimming the lights. We do give our patients earplugs and eye masks. We had a patient recently who we ended up having to send to rehab, and I talked to her that first day, and I said, "How are things going?" She goes, "Well, I forgot my eye mask and my earplugs, so my first night wasn't that great a sleep," but she said that she was going to wear them the second night. So I do think that some of the things that we're doing, they do have an impact. Just short look at, what we're seeing now, 5 months out. Like I said, I don't have a lot of hard data to share with you because I don't think that looking at 5 months is really a wise move. But we've seen no change or influence on our extubation time. We've had a huge reduction in our morphine equivalents in the first 24 hours. We've had a much better documentation of PONV, so we kind of know what our baseline is, at least now, and an anecdotal reduction in incidence of PONV. We've seen a downward trend in our 30-day readmission. Our, knock on wood, 30-day readmission rate the last 2 years have been good, so anything just making it kind of continue on the same path or improving is good for us. We were about 79 to 81% patients discharging home following surgery, and we're seeing that trend actually improve beyond that. I think everybody's trying to avoid the whole SNF and rehab, and we're working really hard to do that, so that's going in the right direction. And patient satisfaction, just with the sleep protocol, I think has been very positive. People actually do like our nutritional drinks. The Ensure pre-surgical clear is pretty awesome stuff. I will tell you, I'm going to be doing a triathlon in about a month, and I'm actually going to use the Ensure pre-surgical clear as my loading dose before I race. So I'm going to see how it goes because it's got some good stuff in it. And then the next steps for us are the methadone protocol and kind of getting the hardcore part of our delirium protocol put into place. So and that's all I got. Any questions?
I just have one.
There's one question back there.
Sure.
How come y'all are using the rectal Tylenol instead of the Omifera?
Cost, and as pharmacy tells me, it's just as effective.
Okay.
We were using IV Tylenol we had 2 surgeons. One surgeon used it, one didn't. And to be honest with you, we really didn't see a huge difference in pain control. And so my negotiation with the whole group was, hey, Shigamidex is not cheap. How about if we got rid of the IV Tylenol, and would that be okay if we did that to cover the cost of the reversing agent? And to be honest with you, we've had no issues with it. Now, what I will say is that, like anything, you have to police what you roll out, and education for this was huge. I mean, we spent a lot of time educating people, but when the rubber hit the road, we spent more time policing it after that. What we found is that some nurses aren't fond of the rectal Tylenol. And so the beautiful thing is, our pharmacist, she would Tiger text me, so-and-so didn't get their rectal Tylenol, so then, you have to write your safe reports and all that. And now the compliance is there, but as with anything, it takes months and months to get, if not years, to get that, to get that traction, and we're starting to get that now, so.
And the patients are all right with that?
Yeah, they're okay with it, yeah. Yeah, they're fine with it. As long as they're not having pain, so. I see a lot of snickers about the Tylenol.
What's Tylenol after heart surgery?
Yeah, exactly. Yeah, maybe pain in the butt.
All right, thank you, Mike, again. We'll hold off on our questions for our panelists, but I'll introduce our third and final panelist, April Howell, who is the Program Director for Cardiac and Vascular Surgery at the University of Virginia. April is here to speak more about, and you brought the whole team here, it looks like, to speak more about the prehabilitation protocols that UVA has implemented and some of the changes you guys have seen thus far. April, thank you.
Good evening. Big shout out to Mike. As each one of you can see, he's very passionate about what he does. VCSQI is about building relationships. And I want to personally thank Mike for something he did for our family. My husband's sister's husband's father went to a walk-in clinic and had this excruciating shearing back pain. Was urgently transferred to Mary Washington with an aortic aneurysm. He's in his late 80s. He's very frail, very sick gentleman. And they were trying to decide whether or not to transfer him to UVA, keep him there, or do surgery or not do surgery. Who did I call? I called Mike. Even though he wasn't on the case, he got permission, sat down and talked to the patient and his family, and spent hours reassuring him and the family. He was discharged home. He's still with us and doing well, and I just want to tell you thank you. Oh, a clicker, which I will probably, just the middle one. My right, you're right. Thank you. Sorry. So, prehab, physical therapy in the ambulatory setting. What in the world is that? Prehab. One of the physical therapists came to me about 2 years ago and said, we want to start a prehab program in your ambulatory clinic. You want to do what? What does that mean? So data-driven, evidence-based, we looked at all the different possibilities what that could mean. Did you want us to refer these patients to cardiac rehab before surgery? We don't always have time for that, do we? You want me to send my aortic stenosis patient to cardiac rehab before surgery? No. So what does it mean? So we compromised. We said, well, what about having a physical therapist come into the clinic and evaluate the patient? Go through a series of exercises, do some patient education, reinforce what we're doing. Well, that might work. Well, who's going to pay for it? That was our biggest barrier. Once we committed as an organization that the clinic would pay for the staff to come in, then it was a go. But then we had to define one of those most difficult things. What is frail? Each one of us thinks that we know what frail is, and Deanna's going to talk about that. Is it that 5-meter walk test? Is it whether or not the patient can sit to stand? Is it, like Mike said, that grip strength? Or is it that eyeball test? Something that we all use every day. I want to introduce Deanna. She's our physical therapist in our clinic. We're very lucky to have her with us today because she had a very exciting event. She had her peacocks hatch eggs today. And she has an albino peacock.
It's a good day. Thank you.
Mike.
Let's see. So the right. All right. Good evening. I'm excited to be here and happy that April invited me to talk about this new program. I've been a physical therapist over 20 years at UVA Hospital, and just this last year being part of the clinic has been a whole new experience for me, and it's been really great and rewarding. So at UVA in physical therapy, we already had the Freed Frailty Index built into our medical record system. So when we started doing some of the frailty testing and functional testing in the clinic, this is what we started with. So it looks at unintentional weight loss, activity tolerance, exhaustion, and the activity tolerance and exhaustion are based on questionnaires, and then we measure their gait speed and their grip strength with a hand dynamometer. And so those are 5 indicators, and the frailty, the more positive indicators they have, the more frail they are. So we started using that, and then our friends in the valve clinic who were doing the TAVRs said the latest research wanted to use this essential frailty tool set. So, and there are many, many frailty scales out there. So we met and looked at the research and looked at this scale, and it basically is looking at a 5-time sit-to-stand. So that is a great functional assessment to do. We actually were doing that just on its own as part of our assessment. So that was very good. And then there's a cognitive screen, which is great. Anytime your patients have surgery, they can have some trouble cognitively afterwards, so it's good to know how they are beforehand. And we actually do a screen. We use the mini cog assessment, where basically you give them 3 words and it's a memory recall. And if they don't do well on that, then we use the mini mental, just a more detailed cognitive test. And then the other 2 points that they look at is hemoglobin and albumin. So looking at nutrition, exhaustion, inflammation. So basically those labs need to be in. So that's where initially I'm like, sure, I'll do this essential frailty tool set as well, but I wasn't ready to give up the freed, because when the patients first come in through the clinic, they don't often have their labs available. So part of my role there is to give real-time feedback, like this person is frail, they have risk factors here and here, and if I don't have those lab values accessible to give the team right then I can't complete the scale. So I've essentially been doing both, which does take a little bit more time, but long-term, we can develop our own frailty assessment tailored to our patients based on looking at each indicator and see how they trend after surgery. So some other functional tests, of course, we still do the 5-meter walk test that the STS uses as a standard. So we do that 3 times and have the average. While we're doing that, to be efficient, I can also calculate their gait speed, which also has their acceleration. So essentially, and that's part of the freed frailty index. They use a 4-meter gait speed. So it doesn't take more time at all. It's just making sure I click right on my timer. So we'll get the gait speed separately. And then the sit-to-stand, which is part of the essential frailty tool set, which I think, honestly, if we looked at just one indicator to predict how somebody's going to do after surgery, that's going to be very indicative. So in the clinic, I'm doing all these tests, and then I'm also getting baseline information from the patients. Who do they have to help them at home? Do they live alone? What's their baseline? Do they use an assisted device? Have they had falls? Do they have support? What's their plan? And a lot of them are very nervous about having any kind of surgery. If they end up having an open sternotomy, I can go ahead and give them education on that. And we have started using the sternal support device that they love. And it's much more efficient because, of course, I'm still doing inpatient. If we go ahead and fit that device on the patient while they're coming in versus after surgery in the ICU when there's lines and drains in the way. And then they get a sense of how it works, and, absolutely, they all love it. So that's been a big plus. And then if they have anything different, sometimes they'll have baseline balance issues or weakness or neuropathy. If there's anything that I could target right then to help them just improve their function, I can do that. And then in general, for the post-op patients, I will encourage them to practice log rolling for getting out of bed, and then practice those sit-to-stand exercises. Any of the cardiac surgeries that we're doing, those are the hardest transitions afterwards. So if they can at least get that muscle memory started before they've had their surgery, that's definitely helpful. We also give information on fall prevention, do a home safety checklist. Often the patients are limited by shortness of breath, chest tightness. They're afraid to do anything before their surgery, so they end up getting weaker. So I encourage them. I teach them an RPE scale, their rate of perceived exertion, so they can monitor how hard they're working. It doesn't have to be a walking program. It can be just getting through their daily routine. And if they are short of breath, pacing their activity, teaching them positions of recovery and sitting and standing, just kind of giving them some control of the symptoms that they're having. When we a lot of times take all the control away from the patient. So these are things that can decrease their anxiety about the surgery because there's tangible things that they can work on, their homework, before they come in for their surgery. And then I just wanted to go over a few cases. This 71-year-old lady came into our clinic with aortic stenosis. Her biggest problem was she was having really bad back pain and leg pain. She's got spinal stenosis. In her workup to get her spine surgery, they found the aortic stenosis, so said that needed to be addressed before she could have her back surgery. So her mobility was not good at all. And then she also has anxiety, depression, other orthopedic background, and she lives alone, so she didn't have a lot of support. She had recently fallen. She uses an assistive device at her baseline, so did all the functional testing with her the first time in November, and all of her tests, like her walk was slow, her gait speed very slow, 4 out of 5 indicators with the freed, 3 out of 5 with the essential frailty, and she could not even do a one-time sit to stand without using her arms, and that in itself can be a risk factor, saying that she's not going to do well after surgery. So team decided, let's bring her back in a month. So brought her back in a month, and she actually was doing a little bit better. Her walk time improved, her gait speed improved. She, because her gait speed improved, that made her pre-frail instead of frail on the freeds. Because she still could not do that one sit to stand, her score didn't change with the essential frailty, but she was a little bit better. And she actually was scheduled to have surgery and then just backed out. She canceled. She also had some pets she needed to find homes for, and she just said, I can't do it right now. So then she came back in February, and she was a rock star. So she, all of her times improved. She's still, that's a slow time, 37 seconds for the 5 times sit to stand, but just that she was able to do it, was huge improvement. And she had gotten one of the medic alert systems, and she said that she was feeling stronger, able to walk a little bit more, and then she was able to have her surgery. She still, because she lived alone, the plan all along was for her to go to rehab, but she was able to leave the hospital in 8 days, did her rehab, and she was not readmitted. So that was great. And I'll just do one other. This is a gentleman who came in. I actually met him on the inpatient side because he had had a syncopal episode and got an L1 compression fracture. So I met him on the inpatient side, getting the TLSO brace, working on just getting up out of bed, and he still was very symptomatic, very dizzy, dropping his blood pressure, very limited because he needed to have his valve surgery. So he went to rehab, and then he came back to clinic. He had just about finished the time for his fracture to heal. So orthopedics had said, okay, you're gonna get your brace off in 2 more days. So he comes into our clinic, in his brace with his hiking sticks. And so essentially, and he's 6'4", looking pretty frail. So, and I had met him and his wife inpatient, so I'm like, oh, you're back, let's see how you're doing. He had done well in rehab, and we did all the testing, and he did so well. So, his 5-meter walk, less than 6 seconds, gait speed, that's one of the highest gait speeds that I've had in the clinic. His only frailty indicator was his activity tolerance because he still had spine precautions, wasn't allowed to lift and do vigorous things. And then his hemoglobin was the essential frailty indicator. That those were the only ones. His grip, 54 kilograms. He's in the over 100 club, so that was great. And the sit to stand with his brace, tall guy, to do that in 10 seconds, I mean, it's just great. So what I wanted to bring up with this particular patient is, you know, he came in looking very frail with a back fracture using hiking sticks, but then with all the testing that we did, you know, it was reassuring to the whole team, okay, this guy can do the sternal precautions. It's essentially the same as the back precautions that he has been doing. And, you know, he hasn't had a surgery yet, but I think it's going to be next week. So it's just very, very encouraging. So anyways, I pass on to Miss Robin.
So I'm Robin. I'm the cardiac surgery nurse navigator at UVA for all cardiac patients. So the benefits of this program, when we talked about initiating prehab in the clinic, I was all for it. My case manager background kicked in, said, let's do this. So some of the benefits are the real-time recommendations that Deanna can give to our physicians to get them better, to get them more ready for surgery. And the one thing she does is she gives them a good program when they get home so that they can actually build up their stamina for the surgery, even if it's 3 days from now. They have things to work on. And she'll go to the surgeon if something comes up and she says, can we wait a while to get this guy done because he could benefit from some prehab. If that's possible, then it's done. One of the other huge benefits is the communication piece. We talk about patient satisfaction, but staff satisfaction. Deanna hadn't been in the clinic very long, and I went upstairs to teach a patient, and I get a text from the attending that says, get Deanna to see him now. And I'm like, okay, I'll call her. So she's in the clinic. I'm like, I got to have you come upstairs and see a patient now. So just them eyeballing somebody inpatient now is resulting in pre-consult consults before surgery, so that's a good thing. We can actually initiate, home health or PT or OT or pulmonary rehab or even orthotic recommendations for patients that need it. The patient experience, patients love it. It does diffuse their anxiety. They're hearing the same story. They're seeing Deanna again when they come into one of her teammates, and she's calling them before surgery, following up, making sure they're practicing getting up and down and using their sternal precautions. We have set expectations with our education. Everything is standardized, so they all hear the same thing. It gives them positive reinforcement, reassurance that we're all on the same page with the care that they're getting. Of course, barriers are always barriers, aside from money. Busy clinics. So our clinic is pretty busy. At one point, the average length of time that our patients were spending pre-op visit was about 2 hours, and that did not count education. That was just testing, seeing people, and that. And so trying to figure out how to incorporate Deanna into that was, she's very flexible. She'll go in. If somebody else has to come in, she'll step out. And so it can be a piecemeal, but it gets done. And then using 2 separate frailty scores, a bit of a challenge. And then, of course, with the EPIC, trying to get inpatient to outpatient records to cross over so that everybody knows what's going on. The future, what we're looking at is with telemedicine. So we actually have a pilot program that we're doing with one of our local SNFs, and we're getting ready to start with Encompass Rehab. We have a telemonitor in our clinic space where we can actually see patients when they leave the hospital, so that piece can be a follow-up, callbacks. I said Deanna's calling patients that are going for surgery that she's seen. We want to spread this to our vascular surgery population also. Figure out what are the best tests that we can do for our patients, and possibly down the road develop cardiac and vascular specific frailty tests for our patients.
So what was the return on investment? So we looked at all of our patients pre-starting having somebody in physical therapy in the clinic. And we looked at the walk test. We had 146 patients in that group. So the length of stay was 7.35 days. After we started having physical therapy in the clinic, the length of stay didn't change. However, our discharge to extended care changed from 21.92% down to 11.46%, which is great. Patients who were readmitted to the hospital, pre 13.01% down to 4.17%. That's my return on investment. Mortality hasn't changed, not surprisingly, but there's so much more in here that we just are trying to tease out the data on, but I am more than excited with these outcomes.
So in addition to prehab, we were developing our ERAS program at the same time, and so everything kind of rolled out all at once. We also introduced a new sternal safe product that I have one if anybody wants to see it. Patients love it. It's very comfortable, and we have not had any issues with patients using it. And we changed our sternal precautions. This was like pulling teeth. But now we actually allow patients to use their arms as long as their elbows are tucked into their side. And so that's been a huge satisfier for patients and staff to get patients out of bed and moving around. The things that we changed for ERAS, for cardiac surgery, med-wise, diet-wise, the other thing that was almost an act of Congress was, it was always NPO after midnight, accept your meds with a sip of water. So now we actually allow patients to have clear liquids up until 2 hours before they get there. And then we have them drink 20 ounces of Gatorade as they're walking in the door. Medication changes, you can see, I think Mike went through most of these. This is what we're doing with our medications, and just a few changes with the Tylenol and the oxycodone. The majority of our patients now being on the ERAS protocol with the prehab in combination, most of them are going home with just plain Tylenol now at discharge, so that's a huge plus.
So we did want to bring you some data because there's a lot of data managers in here. So we've been doing ERAS for about 6 months now. So if you look here in the blue, this is our this is our morphine equivalence interop compared to our morphine equivalence post-op. Morphine equivalence post-op versus what we're doing with ERAS, and then our pain scores. So even though we're using a lot less of the morphine equivalents, our pain scores have not changed. And any questions? No, you can't have Deanna or Robin.
Can I ask a question? What kind of education material do you give them when they go home? Like their prescription for pre-PT, do you have it written? Just tell them what to do?
We don't give them a formal prescription, although sometimes the patients are already getting home health PT or outpatient PT. So I will give them written exercises like the sit to stands and practice the log rolling. So if sometimes it is tailored specifically to them, but if they needed, and we can do if they needed, if they didn't have outpatient PT started, we could set that up as well. And I did have a gentleman who wasn't going to have his surgery right away. He had had, I think, a heart attack the year before and never had done cardiac rehab. So it was getting him back into cardiac rehab. So it's not really, we do have set like the fall prevention, the home safety checklist, and then if they have sternal precautions, going over that with them, and the RPE scale. That's all standard that we give them. But then a formal exercise program kind of depends on how they do and what they need, and the time frame before surgery. If they're going to have it, within a couple days, they can't do that much. But if there is time, or if we put it off for them to do prehab, then it can be more formal.
And when you typically see the patients, the normal patient, we do our pre-op testing usually 3 or 4 days before they're scheduled. We don't have a lot of time, but do you?
It's variable. Some, because there's all different attendings in different clinics, and some, it might be a few days, some it might be a few months. It's variable. But that's where that feedback, if somebody is very frail, and if their surgery isn't, emergent to do right away, that's where we can put them off a little bit, have them get a little bit stronger, and then bring them back in.
So that's the advantage, is she's in the clinic with our surgeons. So as we have initial visits, we have them spaced out 2 per hour. And so our APPs and our surgeons will say, this patient is a candidate for surgery. Would you mind going in and seeing them? That's where we've struggled a little bit, because we are an academic medical center. Our patients see 5 different people as they walk through the door. That's why it takes 2 hours for them to be there, and then fitting her in there as well. At first, there was a lot of pushback. Can we do this? It's going to take too long. Oh my goodness. Now it's, can we get more? Definite benefit. Or where is she?
I couldn't help but make a comment. A year ago, when Kevin Lobdell came up and we went through the ERAS approach, I have to say that I was singularly underwhelmed. I felt like it was sort of struggling for how to apply this to cardiac surgery and to our specialty. I couldn't have been more wrong. And I just compliment each of the 3 centers that you've applied your sort of a unique perspective on how you wish to address this and implement this. And particularly, I think all of us are aware of and have embraced the opioid issue, because that's a no-brainer. But the whole nutrition thing you've done, and particularly with UVA on the rehab and what you, or prehab, on how you've addressed this is pretty inspirational. My concern in what we've seen is that I think the biggest bang for the buck is the nutritionist and the physical therapist, and how we're not using them well enough. How the physical therapists aren't available in the late, and at least in our center, in the late afternoon, and particularly on the weekends. We're trying to act like a 7-day-a-week institution. We're not at all. We're still an 8 to 5, 5-day-a-week. But and thirdly, and I was struck by your comments about, well, we haven't seen the change in the level of meds and the length of stay. But you appropriately talked about the readmission, but I just keep wondering, are we measuring the wrong things? I mean, there's such another area of that we just hadn't thought. We've got the answers, we're not asking the right questions in what we measure. So this is really a great start, and thank you for taking the time and effort, because there are a lot of questions I want to ask when we get back, because I think we just haven't been as aggressive as we could be. But great work.
Well, thank you, Deanna, Robin, and April for sharing all the great work you're doing at UVA. At this point, I think we have a few minutes before our next session is supposed to begin. So are there any questions, comments from programs who are implementing ERAS protocols or ones who might want to? Dr. Shor?
This is really inspirational. Some of this stuff is really impressive. Are we going to share the slides and stuff with everybody just so that we can look at the protocols and best practices in the mission and vision of the college? I think that's great. Thank you.
We've sent some of our education material, our Move Like You're in a Tube.
We had the issues too.
We can do we can get the contracts.
Yeah.
To use.
It's the struggle.
The information. So we created something our own. Kind of like our own. And we'll be glad to share any of the information that our physical therapists give out as well.
Interested in the sternal support device. What is that, and how are you seeing if that's effective in helping?
So we started off using the heart hugger, which probably a lot of the organizations use. We struggled with that a little bit. Don't ask me why. This sternal support device, it has an extra piece to it in which the 2 pieces will now fit together. There's a little tiny thing that kind of slides in there. And there's a pulley system. So you don't have to use your fingers like you do with the heart hugger, right? You just pull it, and it tightens up. Patients love it. We have almost 100% compliance with the patients coming back into the clinic and having the device on at 3 and 4 weeks after surgery, which is pretty amazing for us, where we didn't have it before. We do size it while they're in the clinic pre-op because we found that a whole lot easier. We give it to them in a little bag. We are giving patients toothbrushes, the bottle of Gatorade. We give them everything they possibly need. When the patient arrives into the ICU, they're also getting the eye mask, similar to what you were talking about, trying to increase that sleep. But Robin's our model for our sternal system.
I love this. What's the cost?
All the time.
I want to say they're like 80 bucks. We've not had any issues.
We haven't been charging to the patient. Again, it's one of those return on investments. We have seen a nice decrease, and I shouldn't say this too loud, in our sternal dehiscence. We have been using some of the plating system that is out there with the Rasp protocol, not 100%, but we are using that. With the Rasp protocol, we're not using the specialized chest tubes, so that was another cost that we couldn't weigh it out. But that's the sternal support device. It goes over the gown, yeah, because, right, it seems like it would be, but you can wash those, and it does go over the clothing and over the gown. What the families like about it is there's something that they can reach out and they can pull that pulley, or they can reach and they can tighten it if that patient's having a hard time. We've had some family members, instead of trying to help them up by their arms or anything else, actually kind of holding here and helping them up that way. It works.
We're discussing
We can never get rid of the hard pillow, just saying. The patients still love having that in the.
Is this used in place of like the surgical bras for the women? Because
Oh, no.
Still use, they were in the bra and this?
Yes, because
Wow.
for men, it goes, across the nipple line. For women, it goes above. You still need to keep things where.
So with the move in the tube, I've had patients ask if I could just tie their elbows in for them. So I'm thinking maybe we need to come up with something for the move in the tube for the 6 weeks.
Yes,
My friend is
straight jacket, I like that.
telling you that you would now have different problems, because you wouldn't have any rotation whatsoever.
Yeah, because that's, the weight-bearing part of that is where you have to keep your elbows in, but if it's not a weight-loading movement, we encourage them to move their arms so that they don't get frozen shoulders and let their pain be their guideline. So you wouldn't want to, T-rex them for 6 weeks.
Any other questions?
Is anybody out there doing rigid sternal fixation on a regular basis on all their patients? Betty? And is anybody,
A little bit that way, and as they go back.
okay,
We have one surgeon who does it,
on all patients?
yeah.
Wow,
Sternal blue, I think it's called.
yep. And does anybody use the chest tube system that has the, what's it called? I'm trying to think, I'm drawing a blank. It has the, it's like a Fogarty that facilitates it, yeah.
Wire
Yeah.
of sorts in it that'll go in and
Clears it, yeah.
from the inside.
And nobody's using that?
Them open. It just basically keeps them. Did you do a trial?
We did a trial for like a month and it wasn't.
It's expensive, yeah.
So that'll change in your AFib rate?
We have one comment here.
Hello, my name is Jade, and as Mike pointed out, I am with Abbott Nutrition. I just wanted to congratulate you all on everything that each hospital is doing, and you guys are really being leaders with ERAS. There's just a couple comments I wanted to make. just as some of you are doing things, not everything is getting published out there. It's more hospital experience. You all have people like me, local representatives that cover most of the hospitals that might be in here in this room. And we have, again, this isn't published research, but we have lots of data about outcomes, patient outcomes related to things like you discussed, length of stay, readmissions that seem to be important to every hospital. So feel free to reach out on that. And then the second is yesterday I learned about, you probably already know about this, NSQIP. It's the National Surgical Quality Improvement Program. It started in VA centers, and their goal is to improve the quality of surgical care, and cardiac is a sector of some of the different surgical lines that they're looking at. And based on your mission and your vision, they do share best practices here, case studies. They have a surgical risk calculator that apparently gets around 1,500 hits a day, which assesses the risk of your patients going into surgery. So I know that UVA participates, Winchester Medical participates, Augusta, Carilion, and Lynchburg General are a few to name in Virginia. So that's just a little tidbit of information I thought I could share that might be able to help you in your cardiac initiatives.
And I'll give Abbott a big shout out because we did look very closely at using the product. Our surgeons, when they went to AATS as well as STS, came back with the data and was very impressed with it. We did some taste trials. The product tastes good, so you wouldn't have any complaint like that. We had a lot of pushback from a different piece in our organization with our entire Rasp program based on cost. So if you have the opportunity to trial it and look at their data, I think you may hedge on the other side. Can I say that? Just
Any other questions or comments?
I'd just like to thank all of our panelists. One question before we transition on is, where do we go from here as a group in terms of enhanced recovery? I think we've come a long ways in the last year or so since we heard from Dr. Lobdell a couple times. A number of you are on the ground and running with your protocols, but Mike provided some suggestions for how to measure the impact with extubation, length of stay, readmissions. But how do we keep this moving forward? How do we take the next step as a group here?
Well, I think for us, I think for everybody, we're all trying to do things. I'm going to say this because Eileen's not here, my administrator, but when we take initiatives like moving the tube to the administration and say, hey, we want to change sternal precautions. We've been doing it this way for 25 years and we want to change. And like, hey, that's great. Because the cost, and I know you had mentioned the cost for education is a challenge, but for us, we had to make it work at the end of shift change, at the beginning of shift change. We really didn't get this buy-in from them, oh yeah, spend money on education to get the nurses. We really had to hustle with PT and our navigators, myself, and other clin specs to get that education out. And it was a lot of work. But then when you take initiatives like ERAS and you say, we really want to start this program, and they take it back to their administrators like, that's great, they want to start an ERAS program, and then part of it is free to them, and they love free. And if there's any administrators here, they'll tell you, yeah, if you can do it free, that's great. But then when you start to have to spend money and maybe initially it doesn't translate into savings, that's a hard sell for them. And so I really commend what UVA's done, because that's really, to show your reduction in readmission is just, that's amazing. I will tell you, to get below 5% on your readmission rate from where they started, that's just amazing stuff. But to take that leap of faith and get that investment is a challenge. I mean, for me, I think what I'm going to go back, and I talked to April earlier this week, and I was just so impressed with what she shared with me. Talked to Barbie about it, and I talked to our director of PMR about it. But I know I'll get pushback from that, and I think for me, when you say what are the next steps, I think what I'm going to try to do is go back and see if I can work with PT to give us something that we can at least start with giving our patients that exercise, some strength building, and maybe do a modified, we already do some frailty testing, but maybe do some modifications to what they're doing, not because we think that that'd be as good as what UVA is doing, but because I struggle getting that money to invest. I will tell you, for those of you who say, the nutrition products are expensive and you can't, your administrators won't pay for it. I'll just tell you, quite frankly, I rarely take time off. So what I do is I donate my money, my PAL money, my vacation money to the foundation. I created a cost center in our foundation for cardiac surgery. I shuttle all my vacation time to that foundation, and I pay for my my nutrition through my PAL time. That's how I do it. And so there are challenges. I mean, we're all faced with challenges. I really don't want to say that, but that's how we do it. And that's sad. I mean, I think there was an article that was published that said that we really are putting pressure on our physicians, our nurses, our clinicians, extending them to do more and more and more without our administrators taking some, what's the word, ownership of that. And for us, I think Dr. Spear makes a good point. Are we asking the right questions? I think VCSQI has done an amazing job last 10 years with AFib prophylaxis and extubation, because I think by and large, we're all really doing well compared to the rest of the 49 states. But in general, I think sometimes we leave things out there that are the questions not asked. Are we really addressing some of the patient concerns? I've said this to our nurse practitioner a lot. I was like, sometimes I feel like, we're doing great. We don't transfuse anybody. They're extubated early. They're not going into AFib as much as they did. But are we really asking some of the other questions? Are we really addressing some of the patient satisfaction issues that we should? I do think ERAS does. Do I think nutrition is going to be the holy grail of it? No, but I think collectively all these things should. But I think it gets to a certain point where somebody's got to make an investment, and that's the challenge that we're up against, Eddie. I mean, that's the best way I can put it. So.
Thank you, Mike. Well, let's give another round of applause to all of our panelists here. I think enhanced recovery is an item that is not going away, so we'll keep this on our list of topics for VCSQI in the months and years to come here, I'm sure. So our last presenter of the day will be Gyula Sziraczky, the president of Armis Corporation. Gyula, we got to hook up your laptop here, I think. You have some confidential restrictions on there or something, but Gyula will provide an update from our VCSQI clinical financial data tool. You have and so I'll just opine here briefly as Gyula's getting this set up. One of the really unique aspects to VCSQI, and that really allows us to measure the impact of initiatives like enhanced recovery that we've spoken about here for the last hour or so, is our clinical financial data tool. Believe it or not, Virginia is the only regional entity that has a linked clinical financial database like this. So to complement the clinical data from STS and ACC, we've matched up a number of our records with billing data from the VHHA, the Virginia Hospital and Healthcare Association, which is a statewide entity housing administrative claims data. Gyula, I'm sure we'll go in a little bit more in depth on the methodology, but this really gives us an avenue for measuring the results of all the good work you guys are doing here. And so Gyula, I'll turn it over to you for our CV service line financial reporting.
Thank you so much, and I really feel very lucky to be part of this organization for 16 years, actually. And I would like to make sure that I acknowledge Barry Kerrigan with me from Armus, who's VP of Business Development. And also would like to make some statement before we go further that what you guys doing here is not just unique because of the data, which I think is going to be more and more difficult to anybody to get to this point because of HIPAA and patient health information protection, things like that, but also the activities and the attitude and the involvement by everybody in this organization. We are involved with many things, but this is the most dynamic, most versatile, and most forward-looking and moving organization as far as I know. So and my colleagues and my people and the company, we all feel very fortunate to be part of this. So thank you for giving us that opportunity. So moving on, what I'm struggling with for many years is to figure out what's next. What can we do with the data? And how can we change the way we are analyzing data, providing you the necessary results and reports and information to achieve something like the previous panel discussion said from a different point of view. So I would like to show you two new tools which we are developing, especially for organizations like this. This has not been showed to anybody. It's on your data, VCSQI database. And I combine this together, the clinical findings with financial impact. And that's the title of these things. So, so the middle has disappeared. So, so the concept here is to get a set of tools which actually give you two things. One of them is the importance of certain measures, the measures' impact on outcomes. And when we identify this, that's the upper one. When you identify that, what kind of information and what kind of reporting you can run continuously to see if some kind of action has to be taken. So if the system is stable, then you feel comfortable with that, or you still have to do something in order to make it better. So I would like to show you something in an interactive mode right now. So this is the first one. So what you're seeing here is a very simple tool which turns data into statistically significant results. The results are groups of patients which are divided into groups by statistically significant way, and p-value is the indicator here. So the scenario here is that all the hospitals, and you can run this in any other hospitals in VCSQI, the data version can go back to 235, if you want it, and the range, and this is CAB only. Status can be all or elective or emergent. These are random right now. We can extend this in many other ways. And morbidity or mortality is the target outcomes metrics. And this area is just to list additional values to the result, which you see there. And the maximum tree depth, meaning so how far you want to go in order to identify these groups. And then the parameters, the preoperative features, the intraoperative and postoperative. Preoperative is that patient age is significantly influencing results or predict the risk of mortality, which everybody uses for OA ratio. Is that really an indicator of the variation of outcomes? The intraoperative skin incision time, at this point, intraoperative blood, we know blood is a huge indicator, and postoperative blood. So when you run the tree, it gives you the result. And you can see this, let's see just from the left, which is the best possible outcomes, most of the cases. The morbidity and mortality result in this group, which is 3,218, is 2.41, which is remarkably low, is it right? The other spectrum, end of the spectrum, is 62%. So, and everything in the middle. So what contributes to these variations, which is in the database? So this is not theoretical, this is real data. And you see this only when you have enough data to do this, to analyze it. So let's see here. So if the patient has postoperative blood, and the predicted mortality is more than 4%, let's see, and another influential segment is if it's more than 12% is the predicted mortality, then the result is 62%. So 152 patients belong to this group. So, and everything else is between. So let's switch to cost. That's the target is cost now. Now the tree changed, immediately changed. And I'm going to go back, it is a little bit, these are all experimental tools, so it's not released, it's not available to.
Gyula, is there a way you can make the text a little bigger?
Oh, okay, just 1 second, I need 2 hands for that. So, I prefer to see that here, so. So, okay, so what you see here is, as you see, the tree changed, and the contribution and the influential variables has changed. Again, postoperative blood is the most important segment here. Then the predicted mortality is greater than 4%, but instead of having another group of predicted mortality differentiator, intraoperative blood became an influential when you're looking at cost. So that result is $67,000. The next one is $57,000, et cetera, et cetera. The minimum is $31,000. If you don't have blood, if the risk is less than 1.3%, and suddenly the patient age is important if it's less than 40. Now, you can play with this game over and over again before you get tired. So what we're going to do next is to use artificial intelligence to simulate this thing as long as possible and come up with the most influential tree structure at that given moment. As soon as data comes in, more patients, this is changing. It's a dynamic way of looking at data, completely different than just looking at the averages. So, so once you have this, and we did some studies, and go back to the presentation. So this is the control chart which I was talking about. So control chart can be used to monitor performance of the system. And it's based on the previous study period, control period, and this particular case from 2012, I guess, until 2014, in a quarterly basis. And from then, the prediction of monthly operative mortality and mortality rate can be seen. And over time, you can also see prediction of what is coming. And then in this case, you can see the tolerance is widening. So you have more room to stay within the system. Now, you can stay within the system and say, okay, I feel comfortable, but mortality rate is high. So then you have to go back and find something, how to do that. So how to make it lower, but also significantly lower. And this is the chart which tells you if it's significantly lower. So, depending on how you're going to change this, could be 1 standard deviation, 2 or 3 standard deviation from the middle. The dot lines is the mean over the years. And the variation from that dot line tells you the performance results. Does anybody have any question right now? Okay. So these are the 2 tools which I use to focus on the 30 days mortality, morbidity or mortality, prolonged ventilation, AFib, re-op, and blood transfusion. The data source is ranging from 2014 to 2018. That's to, I think it's a little bit more than one data version. Cabbage case is only at this point. The total population for this particular study is 14,315 patients. And the financial details is the total cost. A result is the total charges times RCCs. So it's right now it's the total average of the group, the VCSQI. This is a busy table, but if you are an ARMIS user, you can do that. It's done by the summary table. The reading is that actually very simple. If you start from the rows, you go across, and you can see that there is a 9,172 events with no postoperative event. So I use that, by the way, later as a base price. So remember that one. And that morbidity or mortality is an error. And I could not figure out what is that, because it's not supposed to be 3 patients, is it right? You're going to have a mortality and claiming there is no event. So it's a data error. And there are 3 records in the VCSQI database during this area, during this time, which has operating mortality, no. The patient is dead within 30 days and released the hospital as alive and died. I could not figure out how to eliminate these 3 as an event, because in the database it became a non-event. So, by the way, I find out a lot of interesting questions by doing this. Again, it's experimental. I didn't have time, and unfortunately, I lost a major resource for me to validate all of the definition and exclusion inclusion criteria. A couple of months ago, you guys know that. So going down, and then this area, you can see the no blood has been, so the no postoperative event correlates with no blood in almost 7,000 patients, 1,278 intra-blood, 1,400 something postoperative blood, and etc. So you can read this and find out interesting results of how certain measures correlate in a table like this. So instead of, again, looking at just the average vent hours, you can go to the prolonged ventilation hours and go across and see how other variables or measures correlates with this event. So the next step is combine the financials in here. You have a question? Okay. So this is just the percentages, the same way. By the way, so this segment here is exactly the same as this one. So you can read the table horizontally or vertically. This is the linear regression chart combining length of stay versus cost. As you see, there are plenty of outliers. So I divided into 2 groups. One of them, everybody, another one is the maximum length of stay is 32 days, and the maximum amount of cost is $250,000. And you see the comparisons. So this is the first one, operative mortality. As you can see that the quarterly result is relatively stable. But if you look at the monthly variations, you see immediately a variation of mortalities month by month. The good news is that here is getting much, much better, but again, there is a peak. So here's the first one. So the base cost is $42,370 for the group of patients. It was 9,000 some hundred patients who did not have any result, any event whatsoever. And so the mortality case is 238. There are 249 in morbidity or mortality correlation here. AFib only 7, AFib is 103, so AFib could be something else, plus the morbidity. Again, numbers has to be verified, some kind of funny things going on here, and we can go back. I just would like to show you the concept. And on and on and on. And this is the important things. Mortality rate, 1.8% overall during this time, but it contributes 4% of the cost. And the variation again, so I always encouraging everybody who wants to see cost not to focus on the amount of money, but the impact of certain kind of patient group variations on the baseline, because that's more important. Everybody can have a different kind of cost structure, but if you look at that, that your cost goes up by 265%, and on and on and on, 338, 282% compared to the base price in certain situations, then it's easy to pay attention to these variances, right? This one is the median, so it's lower, but the impact relatively the same. Is that right? So you can take off of the outliers in both cases, but you're going to end up with the same, relatively same result as a percentage change. So, I'm sorry? Yeah, we have a few more minutes. So that's mortality, operative mortality. That morbidity or mortality is even more, oh, that's a glitch here, I'm sorry. Yeah, I'm sorry about this, there's last minute changes. So here you see the morbidity and operative mortality. That's a group of patients who has a finite number of events like reoperation, prolonged ventilation, stroke, renal failure, mortality, and I think one more somewhere. Again, pardon me? Yeah, external ventilation. That's very low, but extremely expensive. So if you see that there is that is 11%, but takes 20% of the overall cost. So any reduction of cost and event can significantly, more and exponentially reduce the cost. So not just looking at the cost from one perspective is one issue. Looking at this chart and see which is the most important correlation here that can influence the cost or saving or patient outcomes is a little bit more defined and more precise to see this kind of things together.
So Gyula, by that chart, prolonged ventilation only, go back.
Just, I don't know where is this going. Oh. Yeah, here.
Prolonged ventilation only in the coronary bypass patients increased their overall cost by 152%. Right?
Yeah.
And yet, the incidence, where's the slide that shows that the incidence was only 6%?
No, it says it's 15% of the overall cost.
Not prolonged ventilation only.
Prolonged ventilation right now.
It was 6 point, yeah. That's,
Yeah, oh, I see what you mean, yeah.
Okay. So just stay with me.
Okay.
It was 6% of patients had prolonged, or 22% of patients had prolonged ventilation only, correct?
Yes, yeah. Oh, wait a minute.
It increased their cost by 152%. So I guess what I'm getting at is
here, okay.
we have a population of patients that may be a low percent of the overall aggregate, but it can dramatically increase the cost.
That's the key.
And what we really need to focus on is the drivers. In this particular case, our transfusion algorithms are appropriate. They're showing that intraoperative and postoperative blood increase the cost in this population by 314%. 314%.
Yeah.
So if we can reduce prolonged ventilation and reduce transfusion, that's a dramatic cost saver.
Immediately.
And so I guess the point I'm getting at is we've been searching for some years about those incidents, those perioperative morbidities that are a low percent in the grand scheme of things, but could dramatically influence the overall cost. So we wouldn't necessarily pay attention to some of these things because they only happen 6% of the time. But yet, that may be some of our bigger cost drivers.
And if you see this here, that one element is the intra and postoperative is 314%, and you don't see this analysis and numbers anywhere. It's either intra or blood, which doesn't make any sense if you're looking at the charts.
Yeah, it seems to me, I just wonder as I look at intraoperative and postoperative transfusion of blood, I would presume that's because there's something else going on. They have
the highest association with postoperative renal insufficiency and trolley.
There's a reason they got blood.
Exactly, that's the point I was saying.
No, I would beg to differ. The reason they got blood is variable on every institution here.
Yeah.
It's your institutional philosophy, and that's why we see such a broad range from the anesthesiologists and the surgeons, the intensivists, that they've got to keep the credit over 28% or 30% or something.
For hemodilution.
Whatever.
So
that's the problem.
how do you separate out those that have a bleeder or some other complication where it's legitimate that they've got blood products? I mean,
Hemodynamic instability, tachycardia, which is the same. There's objective reasons for why we're transfusing them rather than the number of them.
So I guess the question for Gyula is that can you exclude or somehow factor in those patients with hemodynamic instability, et cetera, et cetera?
That's the whole point of this, exactly. So now that of course we can. I just need information and instruction how to structure those tools.
Do you have that data? So for example, they're 22% well, the blood product was 66% or 36%, depending upon.
Mm-hmm.
So if you can figure out what percentage actually legitimately got blood and which percentage.
The one important things here, don't forget this. You read it from here. Every Preop cases has 36% of those patients who have prolonged ventilation have intra and postoperative blood. And the postoperative blood rate among these patients who have prolonged ventilation is 66%. So you can immediately see where are the lowest hanging fruits to do some changes. And getting back to your comments, in another group, there was one hospital where they prolonged ventilation, blood transfusion rate in CABG patients was below 5% consistently until the surgeon left. And everything changed. It's a philosophy, it's a culture, absolutely.
And the other thing that answers your question is if you look after we published all our blood transfusion protocols and the results and all the costs and all that stuff, the Northern New England group went and looked at their 7 hospitals. They, in 70% of their transfusions, they gave 1 unit of blood.
Mm-hmm.
Now, does that make any sense? If you're going to transfuse them, then give them,
This is any product, right? This is not just red.
No, it's any blood product, yeah. But that would be a separate study. Yeah. Okay, so that's AFib.
Yeah, but what's one FFP going to be?
One or nothing. One flight.
So that's AFib, and the impact is relatively big, both on percentage-wise and cost-wise, because there are so many of them. So in this case, the case reduction, basically 1-to-1, almost 1-to-1 reduction of cost, because the percentage will not gonna increase the total cost as much.
But AFib is the only morbidity that can occur by itself.
Yes, and I have a slide, and I was looking at the slide and said, how in the world that can happen? I'll show it to you, move to the back. Yeah, it's I'll remove that because I didn't believe that. But yeah, I know. And this is a re-op. So again, the 3.8% reoperative rate, but more than double the cost, related cost, total cost. So any reduction here is significant.
80% got transfused that were
Yeah,
reoperated.
exactly. So so this is how you read these things, and it's very, very informative. You don't just say, okay, 3.8% reoperated is not that bad. It's not that good. So if you're looking at the numbers and looking at the correlations. So that was the data quality, which I could not figure out how to make these things as an event. Which one? I can give it to you, Joe. This one? Okay.
So Gyula, from here, it's a matter of spending more time and understanding in a reverse way, rather than looking at the percent of morbidities and their influence on the cost, is using cost as the surrogate at the sentinel, because our supposition is that the differences in cost will occur before we have enough patients that die or enough patients with stroke, because they are such a low incidence. It's going to take a lot of patients.
Yeah.
But the cost may change before, with variation from the norm. So we really need to start drilling and looking at how the cost variation occurs, and then see what are those things we can influence. What would be the low-lying fruit here? You know, do we need to readjust our AFib protocol? Do we need to refocus? Because, you know, we've all sort of dribbled off the court on the transfusion, or are we extubating appropriately? You know, those things.
And that's all possible with the new tools, and all possible when we recognize what's important and put this into a machine learning AI environment, which gives us much, much more answers than we ever imagined.
And we can also get this on a monthly basis.
This is on a monthly basis, yeah. Once we have the data, we can run this constantly now.
No, but it's only uploaded to cloud.
No, you went live. That's what you mean?
Yeah. But the real trick with this, though, is if we're really going to make a difference, is we've got to be able to access information, and the database manager will probably kill me before I get to my call. Yeah. But we've got to be able to extrapolate this more frequently.
Pardon me? What? It's live. I mean,
You know how we have the STAR metric?
Yeah.
Can we have this like that on the STAR metric?
You're just reading the whole, yes, exactly. It's going to be a leaf on the STAR metrics report from a different direction. Yeah.
Our users have this STAR metric that you can see how you're doing.
I'm sorry?
Eddie should
Yeah.
be able to get to it for us.
As soon as we getting closer to the questions that is going to be in STAR metrics, please don't ask me any kind of time, because it's a beginning, and we have to do a lot of research on this to make sure that the things which is indicating that, so the control chart gives you a lot of information, and we would like to more specifically focus on what you just said, the protocol, how the protocol impact the outcomes.
But you're saying,
No, it's not available right now. No. It's available. This tool alone is available for us, and if somebody wants to do something with us and experiment and be in a monthly review or something, we would be very, very appreciative.
A mirror image of this with the inpatient cardiology patients, can we?
Yeah, we can increase that then, but we need.
What you started off with the slide on the femoral and radial and all that stuff,
Right.
we could do this.
Yeah, no, I didn't show, but there were slides that we had on charges. We don't have the database yet for the actual costs, but the charges for complications, somewhat like this, doubled, for every complication, it doubled the charges. So if we actually have the cost stuff, that would be.
Well, the RCCs, it's an institutional RCC.
Yes, institutional.
It's not a specific
Yeah.
clinical entity, so we could apply to the charges the same RCCs for each of these institutions.
Probably only the institutional average RCCs. Individually, we group together the RCCs based on the buckets here. You remember the 21 buckets?
A whole different buckets with this.
Exactly, and a whole different kind of template.
That's
It's,
what we're in process, as I
it's very different.
and Eddie, correct me, that's what we're building.
Yeah.
And so with,
We're building that now.
with some of Dr. Sain's help at Carillion, we have drafted a set of 6 or 7 cost buckets for the cardiology patients, which we're working on mapping over to the inpatient cardiology data right now. So hopefully we can get something like that working in the near future.
I have done, did not run the renal failure at this point. So I would like to spend the last few minutes on showing you where we're going with the 3 state reports. And so the Michigan, Virginia, and Washington. So this is focusing on prolonged OE on the 90 percentile. Focusing on 90, maybe you can tell something.
Yes, so these charts are a continuation of a running project that we had performed in the past, again, with the 2 other state collaboratives, showing the 90th percentile hospital across the 3 state regions. So I believe there's 66 or 67 hospitals in the 3 regions. Looking at the 90th percentile site gives us a benchmark that exceeds any of the individual states. It exceeds the STS average. It provides a high hurdle or an insight into what the top performer at those 3 institutions, or sorry, those 3 collaboratives are doing. So if you're not satisfied with meeting the STS average, if you want to take the next step above and beyond, Chris, you've expressed interest in seeing these data. So this is an early incarnation of the next step for our 3 state 90th percentiles.
He actually provided that for me. I think he's run it twice, so that for all the outcomes, we have a 90th percentile. And if you're going to go for 3-star, that's where you have to shoot. It's not,
But even that one, I would like to point out here, it's not just, I was looking at this and decided, what is the real differentiator here among the 3 stars, 3 states? No, the barrier, what is the 90 percentile? Is 0.31. You have to be better than 0.31 in the state of Virginia to be on the 90 percentile range, is right? Here, 0.46 is enough. So this, the issue here is coming up is that you have to look at the numbers in a different kind of context, just the number itself. That's what I'm trying to say all the time, and not all the time, today. Is that really important to see the context. So understand more than just 90 percentile. Because you can see that there's and the cabbage ratio is 48% in Virginia, 45% in MST-CVS, and 51% of COPE. Now, MST-CVS, I guarantee you, is that because of UVM. They're very high volume hospitals, and the cabbage rate is relatively low. Is it right? Yeah, 45%. So here is 51% of the cabbage. In one institution over there, which University of Washington has a very, very high, low rate of cabbage, but everybody else is dominating their performance.
Have you looked at each of the states and what their OE or their average lines look like? Because if it seems to me if you've got that, okay.
So this is the combined ratio. So here is that you have to have 0.36 or better to be a 90 percentile. And you see that Virginia, 2 out of 15 is on that list. Michigan, 4 out of 33 is on the list. And COPE is 1 out of 17 on the list. So I will talk to Eddie a little bit more about this, what other information should be put together.
Yeah, Gyula, on the last slide, if Virginia had an OE, you had less than 0.31, and the other ones were higher.
There's a barrier. There's a barrier of 90 percentile. 90 percentile, yeah. Which means that the quality here is higher. That's
exactly the point. That our bar is lower because on average we're outperforming. That's why I was wondering if we put the lines of what the average what performance would be for each of the states, you would see a separation.
Yeah. Oh, it's not set, okay. So I have to put the separate lines in there. All right, I thought it's in there. But it's seen here. Because if you look at the rolling ventilation for the state, see that? It's improved.
So in my big vision, as we are moving our vision potentially to be national instead of regional, we could share some of our potentially protocols for early extubation and export them if they're, I don't know if they're different or not, or if it reflects different population. But that's an opportunity to figure out best practices. If we're significant, our OE was significantly lower than any of the others.
So where is
Get
that?
the data use agreements that we could use that information from the other two states. See, those are internal, themselves, and really not push that out to be active.
Right. But this, I mean, it's fascinating, right?
So here's the early extubations, right? I put it into the tree.
What we have done, Robert, though, is go to Michigan and present all the blood use stuff, and then they apply that within Michigan, and you saw a dramatic decrease in their blood utilization.
So it's early extubation effective when you don't have post-operative blood. So it tells you immediately. But we need much, much more time and much more machine power to do this over and over and thousands of times and focusing on what's really important, both selecting variables and how does it affect the outcomes over and over again over time. So, but that's just the first baby steps here. And we have now dedicated a team to this, and young people, and we're moving into Google Cloud, everything eventually. And so we're going to have direct access to the AI and machine learning engines through the API, which means that we don't have to transfer data anywhere because it's going to sit there. They are HIPAA compliant, FedRAMP compliant. It's the most aggressively moving company right now in that area. And we have a technology partnership with them right now and have a marketing and business partnership after we pass a certain kind of testing with them. But it requires the technology to use which they're promoting. So it's challenging, but it's going to be very rewarding exercise. Yeah.
Having the cost information is key.
Yeah. Yeah. All right, so that's all for me. Thank you so much for your attention. And
Thank you, Gyula, again for those insights. And we'll work with you to apply more of the cost data and get that shared across the group at future meetings. Any closing questions, comments from our group here? We want to encourage you and thank you for coming here today. Your leadership is commendable. Your feedback is always welcome. And thank you again for your participation and engagement in our group. It means the world to us.